Awesome. Today we have an amazing special guest, Dr. Nolan Williams on Planetary Health First, Mars Next. I am super excited. He is revolutionizing psychiatry, and I've never heard of Psychiatry 3.0 until I heard him talk. So anyway, Dr. Nolan Williams, would you like to just introduce yourself real quick and before we get going?
Yeah, Nolan Williams. I'm an associate professor at Stanford University, where I'm the director of the Stanford Brain Stimulation Lab. So we've been very focused on developing rapid-acting treatment approaches that can get people out of neuropsychiatric illness. Got the world's first rapid-acting neuromodulation approach through the FDA, now paid for by Medicare. Have been involved in psychedelic trials as well. So very focused on that whole space.
Well, this is great. So glad you're here. And so we're going to be discussing the future of mental health treatment, depression, and the rapid acting SAINT treatment. And before we get going, can you just share a little bit what this Psychiatry 3.0 is?
Yeah. So, we've been in multiple kind of epochs within psychiatry about how do we think about, psychiatric illness and mental health. And the first one was, in and around the time of Freud and this idea of a talking cure, like talk therapy is a treatment for psychiatric illness, which, continues on through today and is an effective treatment for a whole host of psychiatric illness, but not completely effective for everybody, right? There's populations of patients where that doesn't work. And then, Psychiatry 2.0 is this idea of the introduction of drugs, medicines into the psychiatric treatment approach. So that started with the oral antipsychotics and oral antidepressants and whatnot. And the idea there was with Psychiatry 1.0, the problem was the content, the thought content. 2.0, it's a problem of neurotransmitters. And Psychiatry 3.0 is a problem of brain circuitry, right? So this idea that brain circuitry is affected in neuropsychiatric illness, and that the solution is a circuit-based solution, whether it be a circuit modulation approach like neuromodulation or something else. So that's the idea.
And now, do you see, I know when I was researching you before having you on, you have a really eclectic background in psychiatry. You did some neurology, and it sounds like with what's going on with Psychiatry 3.0, do you see a lot of these with conditions with depression, TPI, PTS, I mean, all the hosts of these, that there will one day be this sort of psychiatry plug and play? Is that the hope?
Well, the hope is that we can have this kind of comprehensive understanding of neural circuitry, and with that comprehensive understanding of neural circuitry and ability to probe and evaluate brain circuits and provide stimulation to brain circuits such that they can optimally function. That's really the kind of hope and dream. And that's really, I think, the future that we're marching towards, is this idea of being able to, circuit type people and understand their brain circuitry and apply that brain circuitry knowledge into diagnosis and prediction and brain targets for stimulation.
So when you look at what's going on in the landscape, like regulatory, institutionally, with how we go about treating for mental health, what do you think is the biggest thing that's holding us back from really taking care of our population in the United States?
Well, I mean, at a fundamental level, one of the biggest problems is this problem that, of scale, right? With the idea of Psychiatry 1.0, you can only really have like 8 or 10 people, in your patient panel, because you're treating people every day with an hour of talk therapy, and that's not scalable at all with the current numbers. And then 2.0, it's a couple hundred people. With circuit therapeutics, you can treat thousands and thousands of people, across a month or two. so you can treat thousands of people at the same time because you can scale it, and that's really, if, the World Health Organization came out and said one in two people are going to have a mental illness diagnosis at some point in their life. We don't have enough therapists to treat all of those individuals. We don't have enough psychopharmacologists to treat all those individuals, but we may have enough circuit interventionalists to treat all those people, because of the scalability that you can get there that you can't get with anything else.
With this circuit intervention, is this with the TMS? Should we start talking about that? Is that the modality?
That's one. I mean, that's the one that we've done the most work in. That's the one I think that's closest to being front and center in all of it. So TMS is a treatment that was developed in the mid 90s from a device that was developed in the mid 80s. So the TMS actual device is a device that can use Faraday's law and induce current and electrically conducting substances, in this case within the brain, right? So how do you take a magnet, pulse it such that you have enough power, magnetic field out of the magnet to produce an electrical impulse in the brain that you're able to then, with that electrical impulse, change the nature of the brain function, the brain circuit, through knowing exactly where to stimulate in that person's neural network and how to stimulate. What's the signal you're sending into the brain that tells the brain to do certain things or not do certain things.
And so if we are, I know when I was, learning about this, kind of doing my research, it's dialing up, dialing down, kind of like locating by, an actual MRI, the actual specific person's individual brain, and then dialing those centers that we already know. Can you share a little bit about that?
Yeah. So essentially the idea is that you can send kind of three signals in right now. One signal is a signal of turn up. Another one is turn down. So activity, turn up activity, turn down activity. And then the third one is you can send signals in the brain that are inert. They just don't do anything. And that's important to know, because if they just did one thing or another, that would be kind of not in line with the way that we think about things. You really have to think about it in terms of the ability to really send signals that actually, if we said a bunch of garbled letters, that wouldn't transmit information to the person, right? You can say a bunch of garbled letters. You can, in this case, you can say turn up and you can say turn down, right? So you can say things that don't have an effect on the brain. You can stimulate in and have an effect on the brain that tells the system to turn up and be more active. And you can have an effect on the brain to turn it down and be less active. That's really the idea.
So do you see, is there a time where we'll see 300, 1,000 of the locations? Where are we going to find this scalability? Like, where are we right now? And where do you see this, where we can actually scale this up, if possible?
Yeah, I mean, I think the big goal, right, is the ability for folks to see that, and why we've been very focused on rapid acting treatment, to be able to get people out of these high acuity settings and get them well really quickly, right? There's not much that can do that, and do it with very little side effects. And so the ability to kind of go out and at scale work through how to pull that off across different across different illnesses, across different geographical populations. Medicare has come in and started paying, paying through innovation funds to do that. So this kind of new tech APC, new NTAP. So these are innovation funds from Medicare, so inpatient, outpatient Medicare innovation funds. So that's eligible right now. People can go get treated right now that have Medicare, which is great. And that's going to scale and expand over the next couple of years. Yep.
So how in the world did you get involved with this? I mean, you're in psychiatry. It could have been so many different areas in med school that you kind of got into. How did this just really activate you on like, wow, this is really super cool?
Yeah. So when I was a medical student, I felt kind of lost. I didn't really feel like a lot of the things that I was learning about were things I was very interested in. Um, and, really had this kind of electrical engineering, kind of biomedical engineering thinking process that I was into, and really liked circuit boards and circuits and thinking about circuitry, and kind of was at the right place at the right time. The guy that invented the original TMS therapeutic approach is in Charleston, the Medical University of South Carolina, where I was at. And he, I kind of reached out to him, and this guy Ziad Nahas, who was a junior faculty with him in his lab, and was able to really get very interested in that side of this kind of innovation, experimental therapeutic space. It was before TMS was even approved by the FDA, and its original FDA approval in 2008, 2009. I was able to see this in the mid 2000s, get really interested in it, and then kind of go after it. So was lucky enough to have the ability to see that and be in the kind of ground zero for a lot of that stuff really early in the game. So
Otherwise, you would have. So it's just at the right time. It's timing, I would say.
Yeah, I was in the right time. I had the right openness to it, and I was able to kind of see it for what it was and get in and really figure out how that all worked. So
depression, I had no idea how much of a disability it is, even more so in cancer, that just it negatively impacts across the board. And it's such a challenge. What can we do? What do you see as a psychiatrist, how we can reimagine it? Should we have never taken it away from health to begin with? Just sort of just thinking about this as a topic.
definitely, yeah. I mean, I think it's a couple of things, right? So all brain illnesses were lumped together at one point, and then separated, over the last couple hundred years, is a different kind of conceptualization of what they are. And really that, that separation was based off of having like a biological explanation for it, right? So epilepsy used to be thought of as a psychiatric problem, or demon possession, or all these things that people thought hundreds of years ago, and they've become it's become understood as a brain electrical activity issue, right? There's over synchronous firing of neurons. We call that a seizure. Where clusters of brain cells are firing in ways they shouldn't be. And so as we learn more about depression and about the therapeutics and the approaches around depression, we learn more about what it means to to understand that from a biological perspective. We can apply more standard medical thinking around it. Then it will kind of come into the realm of the way we think about the rest of medicine, right? Very typically, if somebody's going to take out a tumor, they know where it is, they know how they're going to take it out. Stimulation is very similar to that, right? We want to know where to stimulate, how to stimulate, and so it's just a matter of kind of acclimating the kind of psychiatric educational process towards more of that sort of thinking, which I think is going to be helpful, not just for brain stimulation, but for other things, even for drugs that have these sorts of effects on circuits.
Do you see there's a lot of openness at this time, or is there resistance in the just general community to kind of collaborate?
There's openness. I mean, I think there could always be more openness to everything, but there's openness. I think there's an optimism that's out there, and I think we're very excited about that. So it's just a matter of kind of getting the ball rolling on doing this at scale. So.
Well, I wish I could come in and look at your laboratory. I could only imagine what's going on there. But you do so
Anytime.
You do some amazing things with, of course, depression, but I'd love to know what is getting you excited. Brain gut, psychedelics. I mean, every time I try to find something, when you're given the opportunity to speak, it just blows me away the stuff that you're able to dabble, or not. I don't want to say dabble, but you're very eclectic and very agnostic in your interest, and I think that's leading to a greater awareness to how we might be able to put these puzzle pieces together to find these cures or these treatment modalities.
Yeah, absolutely. So we've taken the approach, to your point, that we are agnostic to the kind of the perspective or thinking around something being a certain way, psychedelics, brain stimulation, whatever it is, and much more, focused in on the idea of, can this really help people? Is it safe? Is this something that I have, my family do, my significant other, whatever it is? I want to answer those questions first. Is this something that makes sense to me? Is the risk benefit right? Whether it be a drug or a device or whatever. And what we're seeing is that certainly seems to be the case, right? That there's that there's a whole range of therapeutics that seem to converge on brain circuits in such a way that they're able to kind of functionally improve them. And that's really the basis for it. The other piece that kind of ties all this together is the rapid action, right? We think that making people wait weeks to months for a treatment to work doesn't make sense when these are emergencies, and so we're very focused on trying to make these emergency treatments available to people, whether they be drug or device or whatnot. So.
And not only that, it sounds like with TMS, sometimes the duration can be 4 years. I mean, that's just incredible. I mean, of course, it's different, but case by case. But it's just, I don't know. Anyway, that to me, when I hear sort of anecdotal evidence from that, where someone couldn't even get up to, they were so profoundly depressed, and then they have a treatment, and sometimes the duration, I guess it varies. I know you have the.
But the good news is you can keep people well chronically by just giving them more, treatment, more stimulation. So that looks really promising as well.
So tell me about this brain gut and I'd love to know your thoughts on brain gut.
Like the brain gut connection?
Yeah.
Yeah, there are a lot of neurons in the gut, right? So there's a big connection between the brain and the gut. The vagus nerve, extends into the gut, into the heart, other places. There's this view that part of what serotonergic agents are doing is affecting, gut receptors, not just the brain directly. And so there's a whole connection there that we don't fully understand, but that is clearly important, and that likely is bidirectional and able to modulate each other based off of stimuli in the brain as it goes in the gut. Also things that you're eating are getting affected from the gut to the brain. So.
And then psychedelics.
Yep. So psychedelics are interesting, right? They've been around for thousands and thousands of years, as used in human kind of indigenous cultures safely, and some would say in an expert way, in the sense they have known how to use them, not inside of the Western medical model, but inside of their own kind of cultural systems to success, right? And as a Western medical intervention, they've been around for way shorter periods of time, for a decade or two in the 60s, some level in the 50s, and then reemerged over the last 20 years. And what we're seeing is a very strong therapeutic signal. It's hard because we judge these things based off of like the medical models that we now use to do trials. And, these are things that have profound mental effects. It's hard to construct trials that are gonna work, in the medical model, not from an efficacy standpoint, but from like a blinding standpoint and all of that. And so they look very promising, with the caveat that if you interpret them in the pure, strict sense of the Western medical model, you have to think about the fact you cannot blind these. It's not truly a double-blind, randomized, controlled trial in the current ways that we do that. And so there are a lot of people trying to wrap their head around that right now, including regulators.
So what do we, how do we go about, I know there's John Hopkins and some different universities doing it. What are they trying to do to get more efficacy or try to deal with that challenge?
Well, I mean, that particular challenge is something that's kind of come up recently around some of the FDA panel discussions and whatnot. It's hard, right? Because you almost have to come out with a non-therapeutic psychedelic, whatever that is. There's a compound called Salvia divinorum that's used in some Mexican cultures that has kind of a more mixed record as something that was purely a therapeutic. Some people have conjectured maybe something like that could be a control, but it's hard, right? Like, all of the psychedelics thus far that have been tested seem to have a therapeutic signal. So there's not really an inert drug that's also going to produce this profound psychedelic experience, and not have a therapeutic effect. So that's the part that, people are trying to wrap their head around. We've done some work with co-administering ketamine and naltrexone, an opiate blocker, as a way of determining the role of the opiate system in depression treatment with ketamine. And that combo may be, at least for depression trials, an interesting control group, because it's not necessarily something that that's going to be an antidepressant, is what we've seen. And so could you use something like that as a comparison to some of these psychedelic compounds? But yeah, it's hard. It's a really hard problem. It's not one that I don't think anybody's really figured out. How do you fully blind a psychedelic trial? It's like, there's a fun cartoon where there are people sitting around a couch, and then there are people dancing in the center of this circular couch, and then the people that are sitting on the couch go, I guess I know which group I'm in. You know what I mean? So it's one of these things where, like, it's like not easy to blind something that has that profound of an effect.
And then the other thing is, it's such a bizarre I mean, like, it can be I guess the euphoria, and then also I mean, it can create really havoc depending on if the effects can be good, bad, and all the other things. It's not like
and that's why they call it psychedelic assisted psychotherapy, right? So it's a non-specific amplifier essentially kind of amplifier of experience. And so if your experience is really negative and paranoid and concerned and all that stuff, that experience is going to be amplified by the psychedelic. If you're having a good experience in a therapeutic setting with a therapist you trust, that gets amplified. Mm-hmm. So it's pretty rare to have a acutely bad trip in the moment with the therapist, in a controlled setting, whereas it's not so rare and pretty common if you're in the wrong experience, if you're in a place that you're really worried about or you're kind of freaked out in.
So and this might be getting off topic, forgive me, Nolan, but what do the therapists do to try to reset someone if they're kind of in that treatment, they're on a psychedelic for that guided assistive treatment? Is there standard treatment protocols to kind of if they're seeing a patient, client getting a little more agitated, is there a protocol used? Or,
I mean, you usually typically want to exhaust the talk therapy kind of aspect of it first, because you can help guide people through a lot of that. I mean, there are drugs that can stop the trip, that kind of work on that antagonize the same receptor. The viewpoint is you really don't want to do that unless you absolutely have to, because the nature of the trip and the experience isn't predictive of the therapeutic effect, right? So you can have kind of a what they call bad trip or have a negative experience in the actual drug effect in the moment, and then be out of depression when you get out of that. And so
Wow.
yeah, and so stopping that effectively stops the therapeutic potential.
So it's kind of like a storm. You got to go through a storm to get the rain and to get what, anyway, it's not a good analogy, but it's very complicated, I guess, to say the least. I want to just this Benjamin Button effect with ibogaine. I never had heard of ibogaine until I stumbled in this curiosity with all these different treatments. Can you share a little bit about ibogaine and this what this Benjamin Button effect is that it has?
Yeah, I mean, it's kind of a joke. So we some of my postdocs really focused on some of the brain-based effects of ibogaine, particularly around this idea of brain age, right? And you can kind of accelerate brain aging through traumatic brain injury and through chronic brain illness. And so they ran this analysis on participants' brain age before they get treated with ibogaine, participants' brain age, a week out, a month out. We also did it with some other placebo approaches and other things. And what we found was that the brain age at the baseline was, I don't know, whatever it was, an average of 40 years old. And at the 1 month mark, it was about a year. The AI was judging it about a year and a half or so younger. Now, it's a somewhat small population. It's not in the hundreds; it's in the 30s. We need to do this with a sham control. There's a lot of other stuff that we need to do, but it's one of these things where I'd never seen anything in the literature that had really reversed brain age, and so it's something that we are very actively looking into, and maybe a potential mechanism that this thing's acting on, this mechanism of being able to have an effect on brain age.
So that would maybe then, I guess, be on some sort of potential dementia treat. I mean, we just don't. It's a little too early, I guess.
Super early.
Yeah. Cool. And so when you I guess when you're looking at advocating for these new treatments and implementing it, what do you see is the most I know you're a researcher, there's limit to your focus is research, but what do you see kind of again how we can move the dial as a population? And I'm also sort of thinking with what's going on with the opiates, the fentanyl. I feel like we have a major, all these are connected. There's so many individuals that have depression. What do you see we can do? I know the Surgeon General just mentioned he's going to put a label, whether that's a good thing or not, about social media. What do you think could be the most effective way to help accelerate these conversations for research as well?
Yeah. So you're asking the question of how do you think about the negative effects of social media and how to kind of combat that, or
I guess what I'm kind of asking, I feel like we're constantly just having siloed conversations, and right now it seems like we've had 100,000, and it's even increasing a year of opiates, which has got to be tied a lot to disability, depression, mental health. We got a crisis, is what I'm trying to say, and it seems like we got to the moon by a moonshot when Kennedy said, "This is what we're doing." Are we in a need for some sort of huge national, major like effort to kind of codify all this into one to
Yeah.
create more?
Yeah, no, it's a great question. I mean, it's a question around who's going to do it, right? Patrick Kennedy, the nephew of late JFK, was kind enough to say that we were embarking with all the saint work into a moonshot for the brain. So we're very interested in that concept, right? And it's this concept of total brain mapping and prediction and all that I was talking about earlier. And I think that's a way of getting us there. That's a realistic way of getting the ball rolling on that set of efforts. And it may be the most important way is to really understand what the illness is based off understanding the brain and the abnormal brain circuitry. We can develop a lot of treatments that way. And so I think that's probably what needs to happen, whether it's the NIH doing it or private foundations or philanthropy or venture-backed startups or whatever. All of those things I think are going to have a role. It's just a question of how they're all going to have a role with each other. So
It seems like the hardest thing is to have all the parts working together. It seems like the opiate problem is someone else's, the depression, the research, the pharma. I guess that's why I'm saying like a moonshot, as if it's a concerted, effort where all of the parties are working together. And and I also worry, and I know I'm getting off topic, forgive me, but I also worry with AI. AI is going to do great, but I don't hear a lot of effort about jobs and purpose. Too. It seems like that is just as much. Of course you can have depression, but if you don't have a social purpose after you get reset, so I feel like those aspects are connected to that purpose. I mean, to that whole goal of trying to solve this problem as well.
Yeah, I mean, we can get somebody's mood better, but we can't fix their life, right? Only they can fix their life. And so, we have these tools that can change people's perception of their level of control within their life. We have these tools that can change, it looks like some of the psychedelic interventions for some people give people a new set of insights into, how their behavior is impacting and all that kind of stuff. But we don't have a good handle ultimately on the on the ways to reintegrate people within society, to your point.
Do you see like the Patrick Kennedy effort could that mobilize us as a country to try to fill in all these gaps together? It seems like that could be sort of the start to try to do this. I mean,
well, he's definitely had he's done a lot of work in the parity space, and I think that part's been very important. And I think that that I think we certainly need to see that mental health gets treated at the same level as heart disease and cancer, to your point earlier, right? I think the other piece of it is, even if we had all the money, what do we do with that money? If we had endless money, would we solve the mental health crisis? I would argue maybe. Certainly we have a lot of optimism on some of it from the standpoint of the stuff that we've been working on. But is there an overall tool kit that ends up being there for everything that we need to do right now to solve the whole thing? I'd say no. I think that we've got a lot of really promising stuff in certain domains, but take schizophrenia, for instance. There hasn't been like a new way of treating schizophrenia. I mean, there's been some TMS trials here and there are other things, but like a new, really profound, really strong way of treating schizophrenia in a very long time. I mean, clozapine or clozaril, whatever, however you want to call that particular antipsychotic. It's the same drug effect. That drug is considered kind of the apex antipsychotic, and it's been around for a very long time, for decades, right? And so, and to my knowledge, I don't know of any new mechanism for treating, psychosis, schizophrenia that's in the pipeline that, that's looking like it's going to have a huge effect and really kind of be a functional cure for the illness. There are these small things people are trying to move around, negative symptoms or whatever, but that's where the limits are to the money. You have all the money in the world today. You're going to need to put a lot of that in more basic research, understanding what these problems are, really thinking about these illnesses in a new way, really doing a lot of work to typify them, all that sort of thing. Where I think there are other areas like PTSD, depression, anxiety, where we do have new experimental therapeutics that if they get over the finish line at the FDA, or some of the ones that are already over that need to just be implemented broadly, then we would have an effect that could be measurable.
And what is the data on peer support? When people get help, when they're getting symptoms, their symptoms are managed with whether it be through whatever treatment, TMS, or you name it. Is there a lot of is there any data on peer support? People mentoring and helping. I know that's a big part of the AA model. What do you see on the data on that? Do you have any research on that?
Yeah, so there's an interesting, and I forget the name of the town in France, but there's an interesting town in France where they take in lots of people with primary psychotic disorders, and they stay with families, and they help these people to kind of reorient back to the world and help them to see what's real and not real and all that stuff. And that town has a pretty nice conversion of improving folks' symptomatology, right? And it's kind of an interesting model. And I think that the world's missing some of that, right? And not to say we bring strangers in and with mental illness and we try to help them with no infrastructure or medical knowledge. I'm not proposing that per se, but just more that it seems like part of it, to your point, is this idea of kind of generalized social support that just doesn't seem to exist, or it exists in these kind of like more governmental kind of bureaucratic spaces, but less in the kind of community level space where it could be even more helpful.
That's fascinating. I'm glad you brought that up. At least something that I'm not just off on Mars or something on this one. Pun intended. Anyway, so I'm really glad you came on. I know you're super busy. Is there anything else you feel that would be, really focused to the depression? I know I went off the rabbit hole, but you can't help yourself when you get Nolan on to talk about some psychedelics and some other stuff other than TMS. But to the topic of depression and the SAINT treatment, the TMS, anything that really is pertinent that we should just make sure we share?
I mean, I think it's the big things I talked about earlier. This is now, SAINT's now commercially available. People can get it through, if they have Medicare, through a number of hospitals, Medical University of South Carolina, University of Arkansas, Stanford soon, other places, Acacia clinics here in the Bay Area. And so if people want to do this, it's now something that's not just a research project, as you were saying earlier. It's actually a full-blown treatment that's commercially available. And I think that's going to be an important, next couple of years to get that done. And, and I think just more generally that there's hope out there. There, as I like to say, as a surfer, in a metaphor, that people are going to be able to be in front of the wave. You're not going to miss the wave. It's unclear when you're going to stand up on the board and, i.e., feel better, but people are in front of the wave now. Like, we're in a point in time where I think there's a lot of therapeutics that are going to be available to people that weren't available before. So that's going to be important.
Cool. Well, I like that we're not at a shore break. We're in front of the wave and there's a good line and we're just riding it through. So you guys are currently trying to then scale up, then get some more sites. Is there any coming to Virginia Beach?
Yeah, it's a great question. I think if there's a if there's if it's UVA or Virginia Tech or whatever, if there's a facility that has the kind of Medicare parameters there, then that would be amazing, and I think there'll be more spots opening up over the next couple of years for that. So that'd be really great.
Awesome. Well, I really appreciate you coming on, and it's really been awesome to have you on today.
Same. Yeah, good to see you. Thank you, Michael.
I appreciate it.